Good afternoon. On behalf of Margaret Hellard from Burnett Institute and myself, Rick Altice from Yale University, we're thrilled to be chairing the session on unlocking the epidemic with key populations. We've got 6 presentations. It will be from several continents and several different key populations. And in order to give our speakers adequate time to get through their presentations, I think we should go ahead and start and get the process. We're going to save 15 minutes at the very end in order to have a group discussion so that we can cross this as a bridging session.
Thank you. I have the pleasure of introducing our first speaker, Rachana Shetty from Nepal, she completed her Masters in International Health from the University of Bergen in Norway and currently is working on a project as the Project Manager in Public Health and Environmental Research at the Environmental Research Centre in Nepal. Rachana is going to speak to us today on why don't key populations access HIV counselling and testing centres in Nepal, findings based on the National Surveillance Survey. Thank you.
Thank you, Margaret, for the introduction. Good afternoon, ladies and gentlemen. Today, I'm here to present on the topic, why don't key populations access HIV testing and counseling centers in Nepal? I'm presenting on behalf of all the co-authors. Let me start with the background. In Nepal, the population, there are 29 million population. This is one of the low-income countries. The first HIV case was detected in 1988, and since then, the country was experiencing concentrated HIV epidemic among key populations, such as female sex worker, men who have sex with men, transgender, and people who inject drugs. HIV testing and counseling service was started in 1995, and currently more than 170 HIV testing and counseling services are available throughout the country. The main aim of our study was to assess the demographic, behavioral, psychosocial, and structural factors associated with non-utilization of HIV testing and counseling services by female sex workers and men who have sex with men and transgender people in Nepal. This slide includes the definition of key terms we use in our study. Psychosocial factors are the factors that influence a physical health outcome or behavior through our psychosocial mechanisms. Structural factors are positive and negative factors that influence HIV prevention behavior of an individual, and they may relate to physical, economic, social, policy, and other aspects of environment. Men who have sex with men and transgender are recruited whose age is 16 years and above, who self-identified as either MSM or male to female transgender and reported to have had sexual intercourse with another male or transgender in the past year. Female sex workers were recruited whose age is 16 years or above, reporting to have been paid in cash or kind for sex with a male within the last 6 months. So this is the map of Nepal, which shows the study area. The blue one is Kathmandu Valley, where MSM, men who have sex with men and transgender, were recruited from 3 districts. There are Kathmandu, Lalitpur, and Bhaktapur districts. The main capital city is also situated here. The orange color was the 22 Tarai highway districts, which shares open border with India, and female sex workers were recruited from this site. People who inject drug were also recruited from this site in a national surveillance survey. However, we haven't analyzed PWID data in this study. 400 men who have sex with men and transgender were recruited from 3 districts using respondent-driven sampling, and 610 female sex workers were recruited from 22 districts using 2-stage cluster sampling. Our outcome variable was, have you visited any HIV testing counseling centers in last 12 months? And we have documented the reason for visiting, such as pre-post HIV test counseling, information on HIV/AIDS, HIV test results, and etc. These are the independent variables we analyzed in our study, such as socio-demographic, behavioral, psychosocial, and structural factors. Under psychosocial factors, we also analyze depression, suicidality, social support of the study populations. For RDS-related data, we produce RDS adjusted prevalence based on the network characteristics of each participant. To find association between outcome variable and independent variable, we produce adjusted prevalence ratio with 95% confidence interval. So now result. The prevalence of non-utilization of HIV testing and counseling was 55% among female sex workers and 69% among men who have sex with men and transgender. Around 20% of female sex workers and men who have sex with men and transgender were adolescents. 75% of female sex workers' clients use condom in their last sex, and 76% men who have sex with men and transgender use condom in their last sex. Female sex workers who experienced sexual abuse in last 1 year was 20%, and 6% among men who have sex with men and transgender. 6% of female sex workers ever injected drug, and only 1% ever injected drugs among men who have sex with men. We also analyze other variables such as depression, suicidality. So around 50% of female sex workers experience depression, and 33% experience depression, and 33% of men who have sex with men experience depression. Among female sex workers, 35% thought of suicide, and 14% thought of suicide among men who have sex with men. Suicide plan was 32% for female sex workers and 42% for men who have sex with men. And we have asked about suicide plan and suicide attempt only to those female sex workers and men who have sex with men and transgender who experience suicidal ideation. These are the factors associated with the non-utilization of HIV testing and counseling among female sex workers. Those female sex workers who ever inject drug, who experience forced sex in last year, and who experience depression are more likely to non-utilization of HIV testing and counseling among female sex workers. These are the factors associated with the non-utilization of HIV testing and counseling among men who have sex with men and transgender. Those men who have sex with men and transgender, adolescents, MSM, and transgender were more likely to non-utilization of STC. And condom, those men who have sex with men and transgender use condoms at last anal sex were more likely to non-utilization of STC, whereas those MSM who are who experienced forced sex in last year were less likely to non-utilization of STC. There is no consistency between female sex worker and MSM for the forced sex in last year. This may be because men who have sex with men and transgender are more networked people, and they are more networked and they are more encouraged to use the services. So in conclusion, our study have a high prevalence of sexual abuse, depression, suicidality among female sex workers, MSM and TZ in Nepal, and these factors are also negatively associated with non-utilization of SDC. However, no efforts has been made to address the burden of these factors among key populations in Nepal. Study population who are highly practicing risk behavior, such as injecting drugs or non-use of condom with clients, were less likely to obtain HIV testing counseling. Programs should target female sex workers, men who have sex with men, and transgender at increased risks of HIV to improve the uptake of HIV testing and counseling. Currently, country efforts are on distributing condom, lubricant, and wearing key population about available services, but we should also address the burden of psychosocial and structural factors among key populations. If we address these factors, it will help us to achieve first 90, otherwise we will remain in the same position. So before concluding, I would like to thank study participants, National Center for AIDS and STD Control Nepal, the Union, and surveillance survey related to activities which are funded by the Global Fund. And I would also like to thank IAS 2017 for giving me this opportunity. And thank you all for being here. Thank you.
Thank you, Rachana, for that very nice presentation and sticking to time. That's always one of the issues that we try to stick to. Our next speaker is Elias Da. He's a physician and a researcher who's been working in a community medical center in Burkina Faso since 2009. And he is going to be presenting work from a project that he's been involved with that is entitled Feasibility and Acceptability of Immediate ART Initiation in MSM in West Africa.
Thank you, Chair. Good afternoon, everybody. Before starting my presentation, I would like to apologize for the quality of my English. My communication is about feasibility and acceptability of immediate antiretroviral therapy initiation in men who have sex with men in Africa, in West Africa. Formerly, WHO recommended to start ART in asymptomatic patients with a CD4 cell count above a certain threshold level. Some international studies show the benefits of early ERT initiation that might be clinical by reducing mortality and morbidity related to HIV infection. It might be also public health by reducing HIV transmission. In 2015, WHO recommended to start ERT in all infected adults, regardless of WHO clinical stage and at any CD4 cell count. Men who have sex with men in West Africa are vulnerable. HIV prevalence is high in this population, and it's range between 15 and 20%, and it's more important than in the general population, where it's ranged between 1 and 3%. Moreover, MSM are limited access to prevention and care tailored programs. So MSM, like the other key population, are at the heart of the HIV/AIDS response. In this context, we conducted a study which aimed to assess the feasibility and the acceptability of immediate ERT initiation in MSM in West Africa. Co-MSM is a prospective multi-country cohort study held since June 2015 in community-based clinics. we included in the cohort men who reported at least one episode of anal intercourse with another man within the last 3 months, men who were HIV negative or discovered the HIV infection, and men who were at least 18 years old. The study sites were Arcade Sida in Bamako, Mali, Espace Confiance in Abidjan, Côte d'Ivoire, Association Africaine Solidarité in Ouagadougou, Burkina Faso, and Espoir et Vie Togo in Lomé, Togo. Quarterly, we offered a follow-up included clinical examination, diagnosis and treatment for sexually transmitted infection, HIV testing, proposition of immediate ERT initiation for those who were HIV positive, individualized peer-led support for prevention, free condoms and lubricants. We collected clinical and biological data every 3 months, social behavioral data every 6 months. For the identification of associated factors with ERT initiation, we performed Cox model stratify on study site. We enrolled totally on June 2017, 739 MSM, 135 were HIV positive, 50 seroconverted during the follow-up. So totally we had 185 MSM. This table shows you the description of the 185 HIV positive. The median age was 24.4. It was almost the same in the all sites. 73% had a boyfriend. 78% had one or more casual male sexual partners. 40% had a wife or a girlfriend, and 12% had one or more female sexual partners. 98% were HIV-1 infected. 20% had at least one STI. There were less cases of syphilis and hepatitis C, and 16% had hepatitis B. 96% were classified WHO stage 1, and 168, that represents 91%, accepted to initiate ERT. And it was almost the same in the all sites. For those who performed HIV genotypage test, 17% had at least one antiretroviral resistance. This table is about the 168 who have initiated ERT. The median time from diagnosis to ERT initiation was 7 days. Only 14% initiated ERT after the first month. The median CD4 cell count was 422, and almost 73% had HIV viral load up to 10,000. In multivariate Cox model stratified on site, being aged between 22 and 27, being classified WHO stage 2 or 3, or having CD4 cell count less to 500 were associated with ERT initiation. So, in conclusion, there was a high proportion of HIV-positive MSM initiating ERT. The median time from HIV diagnosis to treatment was 7 days, and that means that immediate ERT initiation was feasible and acceptable, and strengthening WHO recommendation. There was also relatively high antiretroviral resistance, and the factors who were associated with ERT initiation were WHO stage 2 or 3, CD4 cell count less to 500, and older age. At the end of my presentation, I would like to acknowledge all the participants and all the co-MSM study group in France, Montpellier, Marseille, and Paris, all the sites in West Africa, Mali, Burkina Faso, Côte d'Ivoire, and Togo. And I would like also to acknowledge the sponsorship, ANRS and Expertise France. And thank you for your attention.
Thank you, Elias. Our next speaker is Flavian Ndonko. He is a medical anthropologist and holder of a PhD in the University of Hamburg, Germany. He is working as an HIV Senior Technical Advisor for Care in Cameroon in a project for key populations, mainly focusing on female sex workers and men who have sex with men. Today he will present an innovative way of reaching clients of female sex workers with HIV testing and counselling services. Thank you, Flavian.
Thank you. Good afternoon to all. I came here 2 days ago, and this place is really big. I keep getting lost, and then it's only since this afternoon that I couldn't get lost again. But I was even able to help other people here who were always looking for where is the Grand Amphitheater, where is the Bordeaux Amphitheater, and so on. So I can now, in my capacity as tourist guide in this place now, I can even work as tourist guide here. But it's to tell you that at times hospitals are even bigger places, and you send people there and don't imagine that they can get lost. And most MSM key population when they are referred to hospital, because I came from Cameroon where female sex work or commercial sex work or homosexuality are all considered as illegal. Luckily, the policemen, they work during the day and most of them sleep at night, so, and the key population, they sleep during the day and only operate during the night. So it's easy to get lost when you're referred to hospital. So I'm talking about peer navigations. These are people who act like these guides to help key population who are referred to hospital not to get lost and to really find where they go. In Cameroon, we have the prevalence of HIV among female sex workers is more than 36%, and also among MSM, it ranges between 24 and 44%. And most key population diagnosed HIV positive were not linked to care because of this high stigma and denial, long procedures for treatment initiation. And there's a wide gap between the number of people put on treatment as compared to the number of positive cases. Even for those already on treatment, an increase in case of dropping out. So there was no active mechanism to track client flow within the community and a health facility levels. So peer navigation system initiated was initiated to support enrollment and retention of HIV positive key population in the HIV service cascade, as well as adherence to treatment. So peer navigators are HIV positive, so they know the place, and that's how they can help others. There are also medication adherent role models who understand and can convey clearly how to assess and utilize key services for people living with HIV/AIDS and their partners. This project is supported by PEPFAR, and the process was initiated and supported also by linkages in 2 pilots community-based organizations, one for female sex workers and one for MSM. So 24 potential candidates were identified, selected, and then they were trained, and they had a 1-month internship in these CBOs. And after this internship, 21 of them were hired and then put on contract. Following this, when they were their recruitment, 838 HIV-positive female sex workers and 557 HIV-positive MSM access services from the 2 CBOs. But preliminary data show that increases in client linkage to care and treatment. About 39% of newly diagnosed HIV-positive clients linked before peer navigation, but after peer navigation were higher, 82% were able to be linked. And that's the same with the female sex workers. We had the 39%, only 39% were linked before, but after peer navigators were higher, 82% were linked, which is really very big difference. And also for those that drop out that we had 71% drop out before, but after the peer navigation were higher, we had 38% drop out. But now there is even less now with the experience they have in supporting others. So I have a testimony of one peer navigator here saying that being a peer navigator brings me a lot of joy and satisfaction because I not only follow current patients, but also help other patients who have abandoned treatment. We encourage them to come back for treatment and health services. We follow them so that they avoid some churches that are pushing them to abandon treatment for prayer only. We tell them that they should not, for any reason, stop treatment. We really are helping save lives, a lot of lives. We become like family members because through our role, we really help reduce the number of deaths in the community. I'm grateful that I was trained as a peer navigator to support others living with HIV. And this is from one of these peer navigators. So to conclude, I would say that an increase was observed in the proportion of KIPI on ART with peer navigation. The likelihood of putting KIPI on ART was about twice as high with peer navigation than without it. This approach appears promising for KIPI-related HIV programming efforts to reach the second 90 of the UN AIDS 390s by 2020. So I would like to acknowledge the support of linkages who support us, who help us in this process, and also other partners like PEPFAR, USAID, and who support the project. Thank you.
Thank you, Flavian. Our next speaker is Kostya Dumchev. He's a very good friend and colleague, and he now serves as the scientific director at the Ukrainian Institute for Public Health Policy. His research is at the interface of HIV/AIDS and substance use disorders, where he focuses on epidemiology and estimation and program effectiveness. He received his MD degree from Vinnytsia National Medical University and his MPH at the University of Alabama. Kostya is going to be presenting on the HIV treatment cascade analysis for people who inject drugs in Ukraine and identifying the correlates of each level of the cascade.
Okay, thank you, Rick, for introduction. I also would like to thank the organizers for giving me the chance to speak at this conference. My presentation will be about one of the most important key populations that drive the epidemic in my country of Ukraine, as well as the whole Eastern European region. And this session is more of programmatic type, but as an epidemiologist, I couldn't resist putting some methodological nuances in it. So please bear with me on those slides. Okay, so I will talk about the cascade, and if you paid attention at this conference, every other presentation has the word cascade in it, and all those slides. So I thought it was important, to highlight some of the limitations and pros and cons of this type of analysis. Using the example of people who inject drugs. Yesterday there was a very nice session on sort of methodology, and this I will now give some real data, some meat onto that skeleton. All right, so no conflicts to declare. Now I would like to briefly show you why we are interested in people who inject drugs in Ukraine. And the graph to the left shows the new cases, and you see that the epidemic really has grown fast until early 2010s, and now it's starting going down. And the orange part of the bar is the cases which are attributed to injecting drug use. And by attributed, I mean this is the registered mode of transmission. And we know that there is misclassification because this is highly stigmatized behavior. And we actually did a very nice study completed recently, and which showed that you should add at least about a third to these bars to see more or less a clearer picture. Okay, so we see that the contribution of drug users to the epidemic is still pretty significant. And the slide to the right, the chart to the right, is the distribution among prevalent cases from the spectrum model, also showing that there's a pretty good number of drug users there who are HIV positive. So a little bit more on the population. So we have a pretty good population size estimate, which shows that there are 355,000. That was the latest published data from 2013. The most recent shows it's just slightly less. We have incidence data, which shows that incidence is slightly below 2% per 100 people per year. The current prevalence is 22%. This is according to the survey done in 2015, which I'm going to be talking about. And this would, if you multiply this, it gives you that there are roughly 78,000 people who inject drugs who live with HIV. Well, we have pretty good official statistics and reporting, and we have numbers for people who receive ART, and also they report on the number of people who are supposedly drug users, and this is this orange part of the chart, and it does show that it does seem to be like very little number, about 10%. Okay, but there are those limitations that I started mentioning. So there is misclassification, and clinicians don't really are interested much sometimes, or sometimes people just are not willing to talk about their drug use. So there are number of biases there. So that's why actually we undertook this analysis to find out exactly how much error is there. Ukraine has a very good well-established M&D system for HIV, and we do integrated biobehavioral surveys every 2 years since 2007. For all three main key populations, and sometimes for others too. And they, since 2008 and 9, that we should do combined sample here because these were different cities. So basically, since 2008, we are covering all regions within the country. So 27 regions, and sample sizes for drug users reaching close to 10,000. So pretty big representative surveys. And we used 2015 data for calculation for building this cascade that I'm going to present. And also, we, since there are lots of questions in IBBS, we were able to determine the predictors of going up to the next step in the cascade. And to be able to do this, we had to put some specific questions in IBBS. That's pretty straightforward. If you know the cascade, then you have to ask about whether the person was tested before for HIV, received the result of the test, whether he's registered in HIV clinic and receives ART. The tricky part there is that really, to talk about registration and ART, the person has to disclose his HIV status. And remember that testing is usually done after the survey, after the interview. So not all people are willing to disclose, and that's important. I will be coming back to that later. Okay, and of course there is HIV testing, right? So this is the mostly technical slide for those who are interested in details. And here it shows 4 indicators for the cascade that are may vary in different approaches in different countries, but for Ukraine it looks like this. So number of people living with HIV is the first indicator. That's pretty straightforward. That's the proportion of positive results. I have numerator here, denominator, raw percentage, and then percentage for the cascade. Raw percentage means that percentage from this exact question, and then if you multiply it by the population size that I talked about before, 355,000, then you get the absolute number. We had 22% prevalence. That's pretty simple. Then the next bar in the cascade is the number of people who were tested previously and know their status, and that's where the devil sits in the details, because there are various ways to approach this indicator, and for this analysis, and the definition was that these people had to be positive by our testing, and then they also had to respond positively to the question whether they were tested before and received the result. So the proportion there is 81%. The next indicator is the registration question, whether the person is registered in a HIV clinic. In some cascades, you don't see that distinction. There is just one bar diagnosed with HIV. In Ukraine, we see this as a potential important gap. That's why we have 2 different bars for this. There, you should really include that question where the person wants to disclose the status, and that's where it becomes tricky. If you see here, then numerator should really go to the denominator for the next indicator, but here it differs pretty significantly. These are the people who were not willing to disclose the status. But if you exclude them from analysis, then you get 91%, close to 92, people who are registered from those who know their status. If you multiply it by 81, you get 74. Then receive ART, similar approach, people who report being on ART, of those who are disclosing their HIV positive status. So we get 63% of raw indicator, and then 46%. And that comes down to 36,000 people who are injecting drugs and who receive ART. If you remember that slide that was before with the official data, this one, it's pretty drastic difference, because here we have some 7,000 people who inject drugs who receive ART. So that was a very important finding. Okay, so this, for those who don't like tables, here's the same thing in the graph, coming down from the national estimate of people who inject drugs living with HIV, and then it's going down to 46% who receive ART. These are the results of the multivariate analysis. So for the 2-letter indicators, we did multivariate analysis. There was univariate analysis, of course, in the beginning, which I don't present here. So the variables that were significant there, they were included in the model. And what we see in the model, first model was built for the probability of being registered in HIV clinic, is that gender was significant, so females were more likely. Okay, then the older age group was more likely to be registered. Then being the NGO client, that's an important one, so also increased the probability. And then there we have a case management intervention, like community-based intervention developed by Alliance for Public Health. It's kind of similar to what was described by the previous speaker. And we were interested in the effect of that. So it did show that it didn't show effect of current intervention, but what is interesting is that dropping out from the intervention also decreased the probability of being registered. And actually this effect was confirmed by, for the latter part, for the ART receipt. So people who dropped out of case management were less likely to receive ART. On the other hand, people who were currently involved in case management, they were more likely. So this was kind of opposite effect, which was interesting. Other variables remained the same, so being NGO client also increased the probability of receiving ART. Okay, so the limitations of this analysis. So traditional, survey limitations that, there is sampling bias, recall bias. I will not discuss this in detail. Another limitation is that, in that second part, second indicator, if you see it precisely, it may include the people who, if you remember, these are the people who said that they were tested previously. Given the low incidence, we mostly assume that these people were previously tested as HIV positive, but there is possibility that some of them were negative and then they sort of got seroconversion during our study. So there is a potential for overestimation in this analysis. There is an alternative approach, and we had a debate with my colleagues, but it would lead to underestimation. So I guess it may be slightly less, but we are pretty confident with this. And what I think in all these types of cascades, in general, that are generated on survey data, multiplying proportions to proportion is multiplying the error. So that's why it's, you get greater uncertainty at the later parts. Okay, so briefly the conclusions. So programmatic conclusions, you see that ART coverage is becoming higher. If you see compared to the official statistics, we see that people who inject drugs, they receive more ART than one may think, and it's at least as much as in general population. This is important. We may attribute this to a massive prevention program which is run by Alliance for Public Health and with funding from Global Fund, and it does include this linkage component and more recently that case management intervention. So it does. We do also have another study, but to study the effect, but it has to be reported later. Okay, so on the methodological side, we may conclude that surveys are a useful source of data to generate cascades. It's cheap. Yesterday, people were asking, how much does it cost to build a cascade? In this type of analysis, if you have a survey in place, it doesn't cost anything to build a cascade. It allows you to build cascades for some populations that are not in the statistics. It would be interesting to get this last part of the cascade, viral suppression, and but that's going to be done in this next round of IBBS that we're going to have this year. Not have this yet. Okay, so this acknowledgement of funding, this BBS in 2015 was funded by PEPFAR. Okay, and that's it. Sorry for getting over time.
Thanks, Konstantin. We'll be taking questions or discussion at the end. Thank you. I have the pleasure of introducing the next speaker, who is a good friend and long-term collaborator. Professor Kim Page is an infectious diseases epidemiologist and Chief of Epidemiology, Biostatistics and Preventive Medicine at the University of New Mexico. Kim has worked with the Cambodian groups for 18 years in HIV prevention research, principally in female entertainment and sex workers. She will be presenting results from a large multi-level prevention trial that brought together academic researchers, government and community groups in 10 provinces in Canada. Cambodia. Thanks very much, Kim.
Oh, thank you for that lovely introduction. It's a pleasure to be here and really quite a great honor. I'm really pleased to present this, the results of this research study. And, okay, thank you. And I have the mouse on the right, but I'm really a lefty, and so I'm going to try and think with my right and left brain. So the goal of this study, which we call the Cambodia Integrated HIV and Drug Prevention Implementation Study, was to implement and evaluate a new integrated and multi-level HIV and drug use prevention program in female entertainment and sex workers in Cambodia. I have one conflict, well, potentially more, but one, I have received funding from Gilead Sciences for research unrelated to this, and I've been known to hang around with some sex workers. So in 2008 and 2010, this is just some background. We conducted 2 studies that showed that among Cambodian female entertainment and sex workers, the use of amphetamine-type stimulants, or ATS, was prevalent and associated with number of sexual partners, condomless sex, incident STIs, and poor retention in health and HIV care. We subsequently conducted qualitative research, or concomitantly, which identified ATS as a key occupational driver of HIV risk in female entertainment and sex workers. ATS is used as a power drug conducive to working long hours and increasing strength and endurance. Women wanted to see more customers and make more money. So together, all of these results showed the need for new interventions to reduce HIV risk by reducing ATS use and facilitating economic opportunities. The SIPI study was conceived of and included many different steps. We conducted formative research that included exploration of views of incentives and transportation and different factors involved in the intervention, especially the conditional cash transfer and aftercare program that was going to be part of the implementation. Planning was conducted with the National Authority for Combating Drugs and the Ministry of Health and our partners, FHI 360. There was a lot of local capacity that was that we evaluated and data to inform decisions about the approaches and implementation. And as we rolled out the study, orientation workshops were held with multiple stakeholders. So one of the important things about the study in Cambodia was that we leveraged an existing program called Smart Girl. And Smart Girl is actually an existing program. It was developed by FHI 360. It's a targeted communication-based program that delivers standard of care HIV prevention, HIV testing, condom use, and referrals to care. I had someone actually kind of oppose the word girl at one point, but we didn't come up with this. In Cambodia, women and working in the entertainment industry are called things like beer girls and karaoke girl and massage girl. And so Smart Girl is actually a very clever, I think a very clever name for this program. So this little schematic shows you the core of Smart Girl, and what we wanted to do was Smart Girl Plus. We wanted to expand it, and I'll give you more details on that in a minute. The design of our study was a stepped wedge, or was a randomized cluster stepped wedge trial. And this is just a schematic, and I'm going to keep coming back to these little blue squares and the pink squares as we go, but it shows you that we rolled it out sequentially in 10 provinces, and this is kind of what it looked like. In the first blue, we had our baseline outcome intervention, and then we had our basic outcome evaluation, and then our interventions. So the interventions actually comprised 4 different elements. Expanded outreach to engage very high-risk women into existing HIV prevention services, that would be Smart Girl. We used the WHO alcohol, smoking, substance involvement screening test, also called ASSIST, which linked screening and brief intervention counseling for ATS users as well as alcohol use. And for women with problematic patterns of ATS use at baseline, we implemented a 12-week conditional cash transfer prevention program to reduce ATS use, followed by a 4-week cognitive behavioral aftercare program, which was aimed at reducing relapse in these women. So that's the pink square. We also had, for women following the 6-month outcome intervention, women who were ATS negative, either at baseline or following participation in the CCT-AC program, a micro-enterprise opportunity, which combined a 3-day financial literacy training with an optional microloan opportunity. And now our women that we targeted were high risk, principally reporting 2 or more sexual partners, different sexual partners, or transactional sex in the past month. This schematic, again, brings our little blue squares into focus. Our primary outcome of interest was sexual risk, and our primary outcome was number of sexual partners in the last 3 months. We had supplemental sexual risk outcomes, including number of new sex partners and unprotected sex measured various ways. We had a primary ATS outcome, which was recent ATS use as measured by urine toxicology screening, and the supplemental outcomes, which were using the ASSIST score and binge ATS use. Our analyses really basically wanted to compare whether 6-month outcomes, 12-month, and 18 months differed from baseline. So this shows some results, the characteristics of our women. We aimed to enroll 100 women in each of the 10 provinces in which this was rolled out, and we reached 1,198 women. 79% of the women were under 30, 67% did not have a primary partner, about 81% worked actually in entertainment venues, and reported an average monthly income of equal or less than $250 US per month. Using the ASSIST, 34% actually screened positive for stimulant use disorder, and 3/4 screened positive for alcohol use disorder, which is not shown on this slide, and also 18% had clinically significant psychological distress. So here I'm going to show you some results. At baseline, as I mentioned, we recruited almost 1,200 women, and we purposely targeted 600 women in each of our outcome evaluations at 6, 12, and 18 months, and this shows the number of women at each one of these different time periods that we compared, again, to baseline. And so our intention to treat analysis, this was the main analysis, and according to protocol analysis, actually restricted the baseline to 600 women. Here's our primary result, the number of sexual risk partners. We saw reductions in the number of sexual partners at all follow-up visits. Relative to baseline, though, the significant one was at 12 months, where women reported 50% fewer partners. We actually used an adjusted rate ratio for this one. A rate ratio is a ratio of counts. It could be called a rate of partners per 3 months. So thus, women reported 50% fewer sexual partners, adjusting for other factors in the model, which included calendar time, work venue, and random effects, which was province. The adjusted rate ratio versus baseline, for instance, for 6 months, shows a 35% reduction in number of sexual partners relative to baseline. These are some of our supplemental results. What you can see is that women reported significantly lower numbers of new sexual partners over all follow-up visits, 65% fewer partners at the 6-month visit, and 85% fewer new partners at the 18-month visit. No significant reductions were seen in prostate-specific antigen, which we used as a biomarker of recent unprotected sex over any of the follow-up intervals. There were significant reductions in reported condomless sex with paying partners, with women reporting 32, 73, and 72% lower odds of condomless sex at the different intervals. And there was no differences seen in condom use with our non-paying partners. This is our other primary outcome, ATS use. Relative to baseline at 6 months, participants had a 60% lower odds of testing positive for ATS on urine screening. This was not sustained at 12 and 18 months. These are our supplemental ATS outcomes, and what you can see is that there were actually no reductions in odds of screening positive for stimulant use disorder based on the ASSIST, and we used moderate to high as our cutoff in the intention to treat analysis. I will tell you that in our according to protocol analysis, there was a 54% reduction in odds of ASSIST positive for problematic ATS use at 6 months, but again, not sustained over time. Similarly, we saw no differences in reported binge use of ATS in the ITT analysis. In the per protocol analysis, we did see some at 6 months. So before I move to conclusions, let me say that one of the limitations of this particular type of design, this kind of comprehensive approach, is that you can't disaggregate the effects of the different interventions that we did. But I'd like to conclude by saying that our CIPI program, this multi-level approach, which incorporated ATS risk reduction and economic opportunities on top of an existing well-distributed HIV prevention program, achieved significant and durable reductions in sexual behaviors in high-risk female entertainment and sex workers. We did see reductions in ATS use as measured by urine screening at 6 months, although these weren't sustained, and we didn't see these changes as measured by ASSIST. Our ATS prevention package included both a conditional cash transfer and aftercare program for very high-risk users. But the ASSIST, which includes a brief intervention, was included for all women. We really need further research to assess the scalability and improve the durability of both of these approaches. The micro-enterprise opportunity was really very novel. It was the first time that women in this setting had access to any such program. And adding these programs to existing HIV prevention programs is possible and should be expanded. There's several posters that are ones up today on other exploratory secondary outcomes that we conducted, and it's in the track C for prevention, and there'll be more posters tomorrow. None of this, of course, would have been possible without very strong community, civil, and programmatic cooperation and support from all of our partners. And I have many people to acknowledge, and they're all shown here in this slide. And that's it. Thank you.
Thank you very much for that presentation. We have our last presentation before the questions will be given by Barrett Lambden. He's a senior epidemiologist and implementation scientist with the Behavioral and Urban Health Program at RTI International. Since 2011, he's supported the government of Tanzania in establishing the first opioid treatment programs in sub-Saharan Africa and has led several implementation science initiatives. He's going to present some of the outcomes from his work, which includes viral suppression at the first integrated methadone and retroviral therapy program for people who inject drugs in sub-Saharan Africa, and I assume from Tanzania.
Yes. Thank you for the introduction, and good evening, everybody. It's good to see such a good crew of people here late in the day on Monday. As was mentioned, I'm going to be talking about an effort that I've been involved in over the last 3 years to integrate HIV treatment into methadone maintenance or opioid treatment program in Dar es Salaam, Tanzania. And it is an honor to be able to speak about these results on behalf of all the co-authors, including Dorothy Mushi, Jesse Mwambo, Surya Hassan, Alexis Cook, Hanifa Salim has been involved in the past as well as Doug Bruce. So this is specific to Dar es Salaam, Tanzania, and the government of Tanzania first launched an opioid treatment program. It was the first publicly funded opioid treatment program on the mainland of sub-Saharan Africa. It was launched in February of 2011, and the type of opioid treatment is methadone maintenance, and it's been administered as a daily medication. The program has been trying to move towards takeaway doses of methadone. I guess to back up a little bit and talk about the HIV prevalence, overall the HIV prevalence for people who inject drugs in Tanzania is around 35% compared to 5% in the general population in the country. Initially, HIV services were partially integrated into the methadone clinic. So if you can think of the suite of services in a very simplified way as having these three pillars of HIV testing and diagnosis, linkage to HIV care and treatment, and ART distribution, the first and third of those pillars were originally integrated into the methadone clinic. So the HIV screening typically occurred through opt-out HIV testing. For people who were identified to be HIV positive, they would then be referred out to a care and treatment clinic to be linked to HIV care and treatment to receive a lot of their baseline laboratory investigations, eligibility determination, etc. Once somebody would be started on treatment, they could come back to the methadone clinic to receive their antiretroviral therapy co-dispensed with their methadone. And there was some research that we did and published in JAGE that really highlighted that this overall model wasn't really getting us the results we were looking for. And I believe the linkage to ART initiation at that time was around 40% or so of those who were eligible within 90 days of being determined that they were eligible. And so we engaged in a community engagement process to develop the fully integrated model, and the idea was, as this figure shows, was to bring this middle component into the methadone clinic, the linkage to HIV care and treatment, and to make other modifications as necessary, since we were doing a fully, more in-depth, I would say, community engagement process. So what that process looked like was effectively gathering a lot of data from people who use opioids, who are engaged in the treatment program, providers of the opioid treatment program as well, who clearly are offering services. And after collecting a couple of rounds of data from these individuals, we held 2 different community engagement meetings, one with people who use opioids in the program, as well as providers and government stakeholders to really define how we're going to implement this integrated model. We had some ideas of things that needed to occur, but we wanted to really let the people who were asking to access services and the people who were asking to deliver them to help tell us how to do that. So here is what the integrated model ultimately ended up looking like. There was no real concern, or nothing particularly came out around HIV testing. I do think there are some more innovative ways we could do that, such as self-testing, but that didn't really come out with this particular initiative. In terms of that middle component of linking people, of linkage to HIV care and treatment, we trained several different nurses and clinicians from the opioid treatment program. We were originally thinking that we would just train one nurse and one clinician to be the sort of point people, but through that effort, we decided that it made more sense to have more shared responsibilities across a broader group of people within the clinic. We also procured point-of-care CD4 machine to help in determining eligibility. That was a really big bottleneck for us in the methadone clinic. This was really important early on, and then in a couple of months after we implemented the integrated model, which was in October of 2015, a couple of months later, the government of Tanzania gave us approval to move to a test and treat model for HIV. So we were able to get people on treatment regardless of their CD4 count. The other important thing to note is that we offered multiple ART dispensing models. Previously, there was co-dispensing of ART with methadone was the one approach that the clinic had. And then we moved to offering 4 different approaches: a 30-day supply given to an individual in a private location from an opioid treatment program provider, directly observed treatment from a provider. They could also receive co-dispensing with methadone if that's what they preferred, or off-site ART. And this was important really from a number of people who were on treatment prior to this initiative, receiving treatment off-site at a care and treatment center. So the overall methodological approach here is that this was a prospective cohort study to assess viral suppression at 6 and 12 months after IMAT implementation, and to assess for predictors of viral suppression at 12 months. We use routine programmatic and laboratory data over about a 21-month period. Our primary outcome was viral suppression, defined as less than 1,000 copies per microliter, according to WHO's definition. ART-related exposures that we were really interested in were dispensing locations, so whether or not people were receiving the ART at the methadone clinic or offsite at a care and treatment clinic, the number of doses per day their regimen required, as well as the dispensing model, whether they were receiving monthly supplies or directly observed treatment. And potential confounders that we considered in the analysis were age, sex, education, a number of clinical factors such as CD4, time in treatment, hepatitis status, mental health being anxiety and depression in the last month, and victim of physical or sexual assault. And our statistical approach was to use logistic regression with robust variances, and our model included confounders that were moderately associated with viral suppression, meaning a p-value of less than 0.2. So here are some of the results. In total, the 137 clients were receiving HIV care under the IMAP model within the methadone clinic, and 135 of those clients had chosen to be on antiretroviral therapy. There were 2 refusals. And I can say those were informed no's. They were people who received a lot of counseling. They were aware of their status. They were aware that they could receive treatment, but they had chosen not to. Of the people that were on ART under the IMAP model, about 93% or so were on treatment at the end of the study period. 106 or 78% of those had been receiving treatment for 12 months or more, and about 15% had been receiving treatment for less than 12 months, but they were still on treatment at the end of the study period. 6 people had defaulted, 2 people had died, and 1 person had been discharged due to some behaviors that the program was not okay with. The characteristics of IMAP patients on treatment for 12 months, the average age was around 38. 16% of the patients were women. About 37%, I think this is interesting, of the people had a CD4 count greater than or equal to 500 when they were initiated onto treatment. This is really showing that we were able to, once we received permission from the government to start test and treat, we were able to get those people onto treatment under the IMAP model. HCV antibody positive status was 71% among the people who were receiving ART. Okay, and so this is looking at some descriptive statistics of the different exposures that we were really interested in. 77% of the clients were receiving their antiretroviral or receiving their ART from on-site at the methadone clinic under the IMAP model. 84% were receiving regimens that required 1 dose per day, and 85% were receiving a monthly supply of antiretroviral therapy. And this is looking at the proportion of IMAP clients that were virally suppressed. So at 6 months after receiving treatment under the IMAP model, about 73% had achieved viral suppression, and at 12 months that went up to about 83 to 84%. And so looking at the adjusted odds ratio, adjusting for those factors that were moderately associated, as I mentioned in the methods, clients who were receiving on-site ART, so receiving their antiretroviral therapy from the methadone clinic under the IMAP model, had a much higher odds of achieving viral suppression as compared to those that were receiving their treatment off-site at a care and treatment clinic. The number of doses per day was also statistically significant. People who were receiving a regimen requiring 2 doses per day had a lower odds of achieving viral suppression compared to those receiving 1. However, we did not see any significant difference with regards to ART dispensing method. So a couple of concluding comments there. We observed very high levels of retention and viral suppression among IMAP patients on ART. And in my opinion, the success of this model has really been driven by engaging really the people that we're asking to access these services and the people that we're asking to deliver it. To me, that's a critical component of these types of initiatives. Clearly, these are observational data, and that is a limitation. None of these exposures that we were interested in are randomized. Keeping that in mind, a couple of thoughts about some of the results that we did see with regards to on-site ART or people receiving their antiretroviral therapy on-site. I think that it's a very strong possibility that this is a setting where they're able to leverage the relationships between OTP providers and their clients. These are providers that know how to deliver culturally appropriate services to people who use opioids, and that can have all kinds of benefits. In terms of number of doses, this could be a possible surrogate for adherence, especially in the context of unstable housing or not having necessarily the most secure location to store antiretroviral therapy. Adhering to 2 doses per day might be more challenging than 1. And some of the future work that I really believe needs to occur with this in this area is to develop differentiated models of care. This isn't a new concept, but the idea that not everybody needs the same thing. We can use people. We can task shift a number of responsibilities of people who have been able to achieve viral suppression to other cadres of individuals, freeing up time of nurses and clinicians to attend to people who haven't achieved viral suppression yet, or and linking people who are newly diagnosed. And a couple of acknowledgements. I acknowledged my co-authors earlier. This is a NIDA-funded study, and also wanted to acknowledge all the participants in the study. Thank you.
Thanks very much, Barrett. Our speakers have been excellent in keeping to time, and that's allowed us to have an opportunity for questions and discussion. I'm not sure whether we've got microphones in the audience. Oh, yes, we do. So yeah, if people would like to come up, if you could identify yourself, please, and then ask your question or make your comment, try to keep it reasonably brief. Thank you.
Great. Thank you all very much. Tim Mastro with FHI 360. The question for Kim Page. Kim, thanks so much. It's great to see your intervention study on sex workers in Cambodia that was layered on top of the Smart Girl program. I presume that the follow-up was venue-based follow-up rather than any kind of a household. And based on that, what did you learn about the career duration of sex workers in Cambodia? Is this something that is transient, that women cycle in and out of, or is it a long-term occupation?
Wow, that's a good question. First of all, let me say that our outreach was not just venue-based, but it was sort of where locales and hangouts, because not all of our women were entertainment-based. 20% of the women were not in entertainment sector, so they were freelance, guest houses, parks. With the change in the laws, we see a lot of dispersion. And our follow-up was done in the same way. And someone asked me today, how did we get the very high-risk women? Because everything was conducted at the Smart Girl clubs. We did all of our follow-up at the clubs, but we had to bring them in, so we provided transportation. And we really had to work hard because the higher risk women are quite hidden. So we didn't want the low-hanging fruit. We had to really push people and the community folks to go out and find higher risk people. As far as time in the trade, I honestly don't have that data, but most women had been working. We do have data on how long when they initiated and how long they began it. And many women do move around from province to province. So there's quite a bit of mobility, and the median age was 26, and most women get in when they're about 22.
Thanks very much, and it's great to see what a good job that Cambodia has done on decreasing the HIV incidence.
Unbelievable, and we really hope that the Smart Girl program can be sustained.
I think it's actually been called elimination of HIV in Cambodia, or it's on the horizon.
I would really love for you to go visit our poster on Cascade of Care and how important Smart Girl is to engaging women.
Thank you. Sam.
Yeah, I have a follow-up question on that. one of the really difficult aspects of interventions with sex workers is that probably, unless we do something, the demand for sex work services is not changed by that. So that there is a real possibility that by reducing these women's risk behaviors, we're putting other women at risk who see the economic opportunity and fill it. And depending on how that cycles and works out, you can either add or subtract from the total HIV population burden. And I'm wondering, and you've got a wonderful study there, very encouraging in many ways. But I'm wondering if you've modeled those kinds of dynamics so that we can know whether these wonderful efforts are leading on the population level to good or bad results.
We haven't modeled that, but I can tell you that over the many years we've been doing research in Cambodia, the median number of sex partners in the last month has gone down in women who are working in these venues. However, concomitantly, there have been large increases in the number of women who are working in the entertainment industry. Large, I mean exponential. But HIV prevalence and incidence has also been very, very much reduced. So there are many things going on. It's a very dynamic situation that's influenced by many socio-political factors as well.
Yeah, I would recommend that NIH or somebody add to your funding so that you can do some of that modeling.
That'll be great.
So very kind of you, Sam. The gentleman on the back.
Thank you. Kostya, thanks for the presentation. I wondered if you weighted your data and aggregated it and then compared those results of number of people on treatment to the original estimates and how that differed from the presentation of unweighted data.
Can I check who that question was asked?
Sorry, that was to Kostya.
Okay, thank you for the question. No, for this analysis, we did not use RDS weights because of a number of reasons, partially because of this raising skepticism. The prevalence for HIV becomes lower by less than 1%. That's what I know. We did adjusted weights. For other proportions, we didn't do that, but I would assume it's not that much different because sample size is, very big.
Thank you. The question is for the presentation from Tanzania. I wanted to have more information about the delivery of methadone. Was it a daily delivery or do you have a take-home delivery? The second question was about the peer. In your model you present, do you have a model with peer educator?
So with regards to the first question, the delivery of methadone, it is offered as a daily treatment. There's a current initiative right now to transition to the program to take away doses of methadone, but I do not believe that has taken off yet. And in terms of you mentioned peer educators, they are used in the program especially when people stop coming in or like there's gaps in coming in to receive their methadone dispensing. There are peers that are engaged at that point to follow up with the clients in the community to encourage them to come back into the program overall. That component, though, is not specifically integrated into in terms of HIV care and treatment services yet. But I think thinking about these peer models, things like adherence clubs and whatnot, are a really important direction to take with this effort.
Hi, Carmen Logia from University of Toronto. Rachana, I was wondering about your study, if you were able to look at any differences between trans women and MSM, or if you were also able to look at sex work within that population.
Thank you for the question. In Nepal, the female sex workers and transgender, they are more vulnerable. And can you please elaborate your question?
So, Rachana, she's wanting to know if among the MSM and transgender women, if you can disaggregate the data in any way, and among that group, were some of those MSM and transgender women sex workers, and could you disaggregate that as well? Could you separate that out?
You can do that. Yeah. Thank you for the suggestion. Yeah.
Good. I was just curious if you had noticed any different vulnerabilities between the MSM and trans women, but maybe that's for a future.
I have two questions. One question for the researcher in Tanzania and the other one for Nepal. I was wondering if people were also using other drugs. Were they still allowed in the program? And then the question for Nepal. So I was really struck by the fact that there are so many mental problems among the groups that you have studied. What are you going to do with those results? Are you developing interventions for that?
That's for Barrett, yeah.
Barrett, first one, and then Rachana second.
Absolutely, yes. So are people still using other drugs? The reality is absolutely. There are drug screenings that do occur, and if someone is positive for other types of drugs, they receive extra counseling at the methadone clinic, encouraging them to try to stop or to eliminate or not eliminate or reduce the amount of other drug use that that they're doing. But I haven't actually heard of any instances of, there have been occasions where if someone is drunk or has consumed a lot of alcohol when coming for their methadone, they won't give their methadone that day as fear of overdose or things along those lines. But there is other drug use that does occur in the methadone clinic, and the general approach is to try to counsel them on that.
There is no such intervention till that's in Nepal, whereas we can try to take these results and to the focal person of mental health. Thank you.
Thank you. This is a question for the West African research, looking at initiating ARV a question for the West African research. In your findings, you were describing more individual factors that may have contributed to a person deciding to go on and accept ARV coverage. But I'm wondering if you looked at more contextual factors, such as their connection to peers, or was there a specific environment in which these people felt that that's where they wanted to initiate their care? So the question is, did you look at the larger, say, contextual factors that may have played a role in their initiation decision?
Thank you for your question. Yes, exactly. We look for the hardest factors, and these are only preliminary results, and we will do another tests to see if there is some other factors like environment or peer factors contribution. Okay.
Did you have a question?
Yeah. This is Sandeep from India. So my question is to Archana from Nepal. So it's very interesting finding I saw in your presentation. So my one concern is like, you know, your eligibility criteria is around 16 to 16 and above. But India still we are facing too much problems with the, like, the child, we have a strong child protections policies, and, the 16 to 18 is come under that reserve quality. So my question is that how do you reach such age, like around 16 to 18, that population? How do you reach?
Thank you. For the MSM, yeah, we have a network organization, like such as Blue Diamond Society, and we just simply go there and we can take the data from there. Yeah, and yes, and for the female sex workers, the same. We have a different network populations, organizations for them, and yeah.
Are there any other questions? If not, I actually will take the chair's prerogative and ask one question and then maybe have just a brief little summary. One of the things, Barrett, that you talked about in Tanzania is that people really had 4 choices for the way that they would get their treatment of HIV and their addiction treatment. And I'm wondering, given those are 4 potential models, and they had a preference for doing that, and some of the data from the preference studies suggest that when people choose their own one, rather than just looking at co-located versus non-co-located, were you able to look at the data based upon the patient preferences to see if there was any difference between that? I know the numbers were small, as 135
yes, the numbers
people.
are small. Yeah, I mean, we were able to look at I think it would be interesting to look at the 4 different models as a categorical variable. All of the 3 different main exposures that we presented today were all dichotomous, right? And so I do believe, I think that would be one of the next steps. My concern overall would be when we do that, we definitely are going to have small cell sizes, but the analysis should be done.
So if there's no further questions, and I know many of you all are trying to head out of here and get to dinner, I just would like to, first of all, thank the presenters for presenting really outstanding presentations. As a chair, it's always wonderful when people stick to the time, and you did a great job of that, so congratulations. We heard presentations from Asia, Sub-Saharan Africa, and Eastern Europe. We had a rich array of looking at key populations that included MSM, people who inject drugs, and female sex workers, with a fair amount of issues around descriptive issues as well as interventions. I think that it will be important to contextualize each of these various different strategies based upon the location, so context is key. And I would also like to thank the audience for sticking around towards the end of the day. That shows that there was really a lot of enthusiasm for the presentation. And as always, it's wonderful to sit next to a co-chair like Margaret Hellard. Thank you very much.